Thank you very much, Darragh. I would like to welcome you all as well to this session. I am Abdullah Al-Hassoum, a clinical oncologist, and with a special interest in prostate cancer. I do as well breast cancer within the Beats in West of Scotland Cancer Centre. And I will start sharing my screen. Okay, great. Okay, and I suppose also I'd like to thank Darragh, representing Boston Scientific, for inviting me to give this talk. And my topics, or what I would like to go through, is obviously an overview about prostate cancer. So looking at some basic principles that help us all understand the cancer, how we treat it, why it happened, how we diagnose it, and so on. So therefore, we'll touch on something like the anatomy, the statistics, how we diagnose it, and the treatment options. But I'll focus predominantly on the radiation treatment options, and we will also talk about ways to try and reduce the toxicity of radiation treatment, in particular using the hydrogel spacers. So this is a simple way of presenting to you sort of the anatomy of a male pelvis. And what you can see there, the prostate gland sort of right in the center. But the most important really message I wanted to pass through to you is how close it is to important nearby structures. So you can see just above is the bladder, and then the urethra passes through. And tell you what, I'm going to use my mouse as well. Hopefully I can get this to work. Sorry, apologies, it's not functioning that well, but never mind. So what you can see, the bladder is just on the top of the prostate, and just behind it is the rectum. Really, they are in very much close proximity of that. And this is important when we think about managing prostate cancer or in general prostate diseases. We need to think about nearby structures. And the reason why it's important to talk about this and to talk about prostate cancer in general is really because the statistics are quite important, and that this is a very common problem. So 1 in 8 men, unfortunately, will have a diagnosis of prostate cancer in their lifetime. Now, we used to think about this as a disease of the very elderly population, but actually we are seeing more and more younger patients presenting with prostate cancer. So it's not anymore just the elderly population who are affected, but certainly the younger population. And we are identifying subgroups within that. So when you look at the details of the statistics. So, for example, in 2018, just under 50,000 cases where new prostate cancer diagnoses were identified in the UK, and over 11,000 deaths a year. That's a huge number. And if we want to think about the Scotland statistics for that, so basically in Scotland, roughly, we diagnose about 5,000 cases a year. So it's still obviously a huge number of patients considering our local population. Looking at it on a positive note, that most of these men can survive for a very reasonable period of time, and actually we are able to cure more and more. And even those who cannot be cured, they actually are expected to live hopefully and predominantly a normal life with a reasonable quality of life, and for a reasonable period of time as well. So when we think about prostate cancer, it is becoming more of a chronic disease, a long-term disease that can, for some patients, require long-term treatment. And obviously for some patients, we are able to cure them completely without them needing to be on long-term treatments. And obviously, thanks to modern technology, whether this is related to radiotherapy technology or biological treatment, hormone treatment, drug treatment, we can call it, or whether it's to do also with the advances in the surgical techniques that are currently available. So it is multifactorial, and I suppose also the reason for the success in the treatment of this disease is because we are all more aware about it. The public are more aware about prostate cancer, and you can see like this session we are talking about it, and so on. So a lot of people are aware about it and asking about, for example, having if there are any little symptoms, then they are seeking advice early, and therefore we are diagnosing more and more early cancers. So how do we look at the process of the diagnosis? So generally speaking, we can think about it as two ways. One is patients who are completely asymptomatic. They don't have any issue at all, but they have a blood test called PSA, which can be part of a screening program, or sometimes perhaps randomly selected, requested by our GP colleagues. And when it comes back sort of on the high side, then it trigger additional investigations. Or sometimes patients, they go to their GPs for completely different reason, and they have a rectal examination and they identify an abnormal feeling prostate gland. So that can then trigger additional investigations to identify and diagnose prostate cancer. On the other hand, you can have patients who do have symptoms, and that could be in the form of altered urinary function. So they may have increased frequency, or they feel that they sort of change in the flow, or occasionally bleeding, pain, local symptoms, basically, that can happen, and that can lead to these investigations started. What is important to highlight, not anybody having these urinary symptoms mean they have cancer. It does overlap with many other conditions like the BPH, which my colleague, Dr. Jafari, will talk about later on. There is some overlap, and that is important. That there's no need to panic, but at the same time, we need to look into these symptoms in more details. The other aspect of the symptom is that sometimes patients, fortunately, this is not very common, but they can present with symptom of spread of cancer, where they can have like back pain, weight loss, and or other symptom related to the respiratory sort of function deterioration. They feel breathless or have cough, or they develop a lump in the neck, and so on. So it's actually a wide range of symptoms that can happen, but fortunately presenting with these distant sort of disease right at the beginning is not a common thing. Okay. Now, whether they are diagnosed through a screening program or a non-screening program, in general, we will want to confirm the diagnosis by doing a biopsy of the prostate gland. And this is quite important to confirm and tell us exactly what's the type and give us more characteristics of the likely behavior of this cancer. So looking at the biopsy, obviously, a biopsy is, unfortunately, is not a pleasant procedure, okay, but is important to establish the diagnosis. And what you can see here on the right-hand side, any biopsy has to be guided by an ultrasound machine. It used to be guided by just the finger, but obviously ultrasound machine is far more accurate. And you can do the biopsy, as you can see on the right-hand side. The biopsy can be done through the rectum into the prostate, which is the traditional way of doing the procedure. Whereas on the other hand, you can basically do it. I'm just going to try. Here we go. I don't know if you can see my red dot here. Yeah. So you can see here, there is the needle goes through the skin into the prostate area here. Okay, so this is called transperineal biopsy, which is, in my view, is a more civilized way of doing the biopsies, less risk of infection, but it's slightly more complex and more technically challenging. Whereas on the right-hand side, the prostate gland is here, and the needle goes through the rectum into the gland. Okay, so there is a higher risk of infection there, but in general, it's a simple, relatively simple procedure that will give us the diagnosis and confirm the type of the cancer. So why do we need the biopsy? Well, we need to look at the cancer cells. How are they looking? Do they look like a low-grade cancer or a high-grade cancer? So it's important, what we call it the Gleason score, or the grade, in other words, as to, is this cancer likely to behave in the future in a good way or a bad way? Okay, and therefore we can then decide, well, actually, if this is a high-risk cancer, then it does require treatment, and we need to do this sooner rather than later. Whereas some group of cancer that are low-grade may actually not require treatment altogether. So you can see that it does actually help us fine-tune the tumor and then the management. Then we also need to look at the extent of the cancer. So we've diagnosed that there is cancer in the gland, but is it just in one part of the gland? Is the whole gland, or is it going outside the gland? Or is it actually going elsewhere in the body? Okay, so this is what we refer to as the stage of the cancer, or in other words, is the extent. Is it just localized, or is it more? Okay, and that together with the PSA, that give us a comprehensive view of the cancer and its characteristics. So looking at how do we know the extent of the disease? Well, we need to do scans, and typically we do an MRI scan of the prostate. This is a picture of the MRI, and this is the prostate gland here. You can see the arrow here is pointing to this part. Basically, this is where the cancer is. This is the normal part of the gland, and you would expect it to continue all like that, all as white area, all this area, but it has changed. Okay, and that is a clear picture, an indication of cancer. And you can see it's bulging slightly there, okay, which is suggesting possibly it's going through the capsule of the gland. Another example is a bone scan. Now, that's a very common scan we use and to help us decide and look at the extent of the disease. And what you can see there are multiple dark black spots around, dotted there. This is an example of a positive bone scan that shows an involvement of the bones. Okay. Now, unfortunately, we do see these images. And it's important that we assess the bones, because commonly prostate cancer can go to the bones. But we have to also keep in mind, not every cancer goes to the bone. The low-risk ones are much less likely to do that. Now, then we can also use a CT scan. So here, if you look on the left-hand side, okay, this is a CT through the pelvis. Now, what I can say to you is that this is a normal looking CT scan, and will be accepted as normal, basically. But what we can tell is that the anatomy looks normal. But what we can say is that some of these abnormalities may be so subtle that on these images, as on this scan, it may not be really visible to us because it's so small. So there are other scans that can give us the biological activity of the cancer. So it's not just the size of the lymph node, for example. It can give us, it could be a normal size lymph node, but actually containing normal cells, containing cancer cells, sorry. So that type of node will look normal on a conventional scan like this one. But when you look on here, and this is a different scan called Psma scan, which is a modern higher sensitivity scan, you can see there is an activity here and there. So this scan has been taken, this is a slice corresponding to the one on the left-hand side, okay, but it tells us that there is actually activity in a normal-looking lymph node. So that has taken our understanding and our ability to treat the cancer much higher level, and we are much more able in dealing with this sort of cancer and giving the more appropriate treatment. So now we have diagnosed the cancer, we have established the grade, the stage, and the full extent of the disease. And obviously we have to assess the patient as well in terms of their fitness, their general health, their other medical conditions, and if they are on any other medication, because all these are important factors. So therefore, then we can have a comprehensive view of each case, and then we can decide what treatment modality will be best suited for that particular patient. So you can have radiation treatment, or you could have surgery, or you can have an observation or active surveillance. So I'm just going to touch on each one of these. So active surveillance, starting with that, is basically a way that when you have what appear to be a low risk or a low grade tumor, that does not look like it is going to progress or cause any problem in the near future. And what we know is that a lot of patients actually can live a normal life with cancer and not die from it, and may not require treatment altogether. But about a third of these patients may progress and then require treatment. And the challenge for us is to distinguish who is likely to progress and who is not. And there isn't a test that tells us that at this stage. But what there is this close monitoring process, so you can then detect any early change in behavior, and then you introduce the treatment. And that way we can save quite a significant proportion of patients having unnecessary treatment. And for those whom we give them a treatment, it is more appropriately selected for them. For those who have a higher risk disease, who require intervention at this stage, well, then the option between radiotherapy or surgery. And as far as radiation treatment is concerned, we have, I'm very pleased to say, in the Beatson, for example, we have a very high and advanced technology that we can deliver to treat prostate cancer, including what we call it IMRT, which stands for intensity modulated radiotherapy. We also are starting to use the SBRT, which is the stereotactic body radiotherapy, which is a more focused and condensed treatment that goes over a shorter period of time. And we have obviously the internal irradiation, or what's called the brachytherapy. Proton treatment is another modality. It's not something available in Scotland, but available not far away from Scotland, though, and is an option as well that can be considered for some selected patients. But the important thing is there are a lot of technical and medical specification that we need to look at to select the right patient or the right treatment for the right patients. And likewise, when you look at the surgical option, well, it used to be like the open surgery, but that's fortunately not the case anymore. And laparoscopic or more advanced, recently the robotic assisted radical prostatectomy is now the standard of care and is widely available. And when we think about all this, we have to also think about what are we likely to cause to the patient when we are giving them any of these treatments, whether it's radiotherapy or surgery. So we need to think and balance the benefits of the treatments. How likely are we to give the patient sort of significant benefits and in relation to the side effects. So if the benefits outweighs the risk, well, we will proceed. But if the balance is in the opposite direction, well, obviously active surveillance probably is the better option, and so on. So it is a matter of balancing the risk and benefits and taking the patients with their medical history and general health and fitness assessment into consideration. And that is why there really, each case has to be dealt with on its own. And you may find that there are 2 or 3 people appear to you that they have the same prostate cancer, but the reality, they can never be the same. They must be different between one another in terms of the extent, the grade, the stage, etc. But when you put it all together, each patient will behave, or each tumor will behave in its own way. So moving on, radiotherapy is delivered through linear accelerators, a machine like this. And as I mentioned earlier, the radiation can cause damage to the nearby structures. One of the main problems we have here is the bowel and the urinary, obviously, because these are the nearby structures. And this can have a major impact on quality of life, particularly the rectal toxicity with increased diarrhea, mucus discharge, bleeding, and I suppose, fortunately, is rare, but rectal or bowel incontinence is a remarkably distressing, but fortunately very rare toxicity. We've already touched on sort of a bit on different types of external beam radiotherapy on the left-hand side. The IMRT is quite an advanced way of treatment and is now the standard of care generally everywhere. We also use with it IGRT, which stands for image-guided radiotherapy, and I'm going to show you some pictures later on about that. On the right-hand side is the brachytherapy, and I wanted to share some picture to give you an idea about how different it is. And what you can see there is this is an X-ray of the prostate with a lot of tiny little seeds implanted in them. And this is how it looks on a scan basis. So basically, the radioactive seeds get implanted to generate a uniform dose distribution, okay, and deliver the radiation from within. And this is how it looked like in terms of dose distribution here. So the red part is where the high dose area, which should go to the prostate gland where the cancer is. And as you go away, the dose fades away. But what you can see here is that the rectum, which is this part here, okay, is very close to the hot area, or the high dose area, which means it is likely to get a lot of toxicity. And if you look on the right-hand side, there is obviously bladder, the lower part of the bladder is involved as well with the radiation, and that can cause the toxicity in relation to the bladder. And therefore, we always very keen to try and minimize toxicity. So we improve on the efficacy of the treatment, but it's important to reduce toxicity. And one way of doing that and improving on the radiotherapy is the introduction of what's called the spacer device, and the hydrogel is really a brilliant device that we have started recently, in fact, in West Scotland, doing this, and is currently available within the Nuffield hospital. But the important thing is looking at the statistics here. This is the comparison of the bowel toxicity and the bladder toxicity. The gray is without the spacer and the blue is with. You can see the reduction in toxicity that is quite impressive. And this is basically what happened. You've seen the same diagram earlier, but when you put the spacer in, that make a big difference. The procedure, as far as the spacer is concerned here, you can see how the close proximity of the prostate to the rectum. And because we need to add the margin, because the prostate can move, that is what causes the front part of the rectum to be affected. But when you add the spacer in, okay, you can see it better there. It really makes our life a lot easier and undoubtedly improve on patients' life on long-term basis. The beauty of the device is that when it goes in, it doesn't need to come out. It just gets absorbed over about 6 months' time, it just dissolve and disappear. And while it's there, because it's relatively soft, it does not have an impact on the bowel function or indeed the bladder function either. And these are just some pictures here to show you the prostate gland and the rectum before putting the spacer. This is with the spacer in, and you can see the separation. And this is about 6 months later, it goes back to normal. And this is the effect on the radiation treatment with and without spacer as well. Just towards the end, just to say, this is a very patient-friendly procedure, and the device is or the spacer is a biodegradable and is used in other equipments and within other drug preparations. So it's not something that is very unusual, but it is a clever way of putting it in the right location to minimize toxicity and improving on quality of life. So the summary here is that you create more space, you reduce rectal toxicity predominantly, but you also reduce urinary and sexual function, sexual toxicity, and improve on quality of life. And I think at this point, I'll probably stop at this point and hand over back to Darragh. But I will be very happy to take any of your questions, perhaps at the end. And thank you very much for listening.
Thank you, Dr. Hassel. That was excellent. A great overview of prostate cancer. So I'll hand over to Mr. Firas Al-Jafari at this point and welcome any questions through the Q&A box, which we will address following the second talk. Thank you very much.
You're welcome.
Thanks a lot, Darragh, and thanks a lot, Abdullah, for this excellent presentation. I always learn from the oncologists, and I was listening very attentively. It's a very, very interesting technology as well. I will share my screen to talk to you about the management of enlarged prostates. Darragh, can you see the presentation?
Yes, that's perfect. Thank you.
Excellent. I'm Firas Al-Jafari, one of the urology consultants from NHS 5, and I do work as well at the Spire Murrayfield Edinburgh hospitals. So I'll be talking to you today about the enlargement of the prostate, the BPH, which is the benign prostate hyperplasia. This is a totally benign condition, which has nothing to do with cancer. But of course, as Dr. Al-Hassel was saying, some symptoms when patients come to be looked for, who come to look for symptoms for enlarged prostates, get their prostate cancer diagnosed. So the prevalence, so it's a very common condition. LUTs, as in lower urinary tract symptoms, do increase with age. Over the age of 70, around 50% of men do have mild symptoms, while over 90% of men between 45 and 80 years old have symptoms sometime during their life. So it's quite a prevalent condition. And in America, around 28% of men do have moderate to severe symptoms which do require treatment. This presentation, these graphics were done around 5 years ago. And at that point, 11 million men were suffering from significant BPH symptoms requiring treatment, with 6.2 million actually having had an intervention done to. The symptoms of enlarged prostate increase with age, with the size of the prostate, but also with the PSA. There are lots of guidelines which talk about the management and the diagnosis of enlarged prostates, but I'm not going to delve into those into lots of details because I worry that I might bore most of you. I will just take you through what are the lower urinary tract symptoms. So they're split into symptoms of men who cannot pass urine and men who cannot hold urine. So I'll start talking about the symptoms of not being able to pass urine, which are called obstructive or voiding symptoms. So men would be having hesitancy to pass urine, where you get to the toilet, you unzip, and you want to pass urine, but then you have to wait a few seconds, and sometimes up to a minute or so for the urine to start. Intermittency, as in the flow gets started and stopped and started, where there's an intermittent flow going on. The flow usually is relatively poor. Towards the end, some men do have some dribbling. At the end of passing urine, you might feel that you haven't fully emptied, needing to go back again relatively quickly. Usually for these men, we get them to pass urine into a machine, which is called the uroflowmeter, which shows us what the flow is like. Usually the flow has to be strong and nice and to finish quickly, but when men do have obstructed symptoms, you see that the flow is quite protracted, longer, and is quite poor in comparison. So that's the speed of the urine coming out by mils per second. On the other hand, you've got the irritative symptoms, which are the storage symptoms, where men are not able to hold urine long enough. And the symptoms are frequency, urgency with urgent continence, and nocturia, which is waking up at night to pass urine. Frequency, meaning that you need to go to the toilet more than once in 2 hours. Urgency is when you have the feeling to go, you cannot hold. Urgent continence is when you cannot hold, you start dribbling on your way to the toilet. And you got this picture where it describes the bladder control. This is the obstructed part where the bladder, the urine is not able to get out. The bladder is telling the urine, you're not leaving. And on the other side, you cannot hold the urine as you're very, very controlling. Many times men do have both symptoms, but when we start getting involved is when the blockage part of the symptoms is a bit more pronounced than the overactivity. The initial patient evaluation goes with seeing you in clinic, and we take a history, we do a physical examination, which has to include a digital rectal examination. There are very minor exclusions where we cannot do a digital rectal examination when a patient already had previous surgery to their rectum, and sometimes that will preclude us being able to examine, but otherwise all patients will get a digital rectal examination. We do ask you to fill some questionnaires for some symptom scores, and then we can compare them when you come to us in clinic and then after treatment. Voiding diary, when we see you in clinic, we would ideally want you to keep a diary of 3 days before coming to us. What you drink, how many times you go to the toilet, how much are you passing urine every time, how many times are you waking up at night, what are you drinking, and how many times you are getting incontinent. A PSA is very, very important, and I mandate to have a PSA for any patient who comes to see me for enlarged prostate issues, because as Dr. Al-Hasso said, sometimes that can incidentally pick up prostate cancer, and that PSA could be a lifesaver. Post-void residual, so after we see you, we get the test that we've shown you with that flow, but then we measure with an ultrasound how much urine is left behind. And sometimes we do measure how big your prostate is. There are assessment algorithms which are vetted, which we go through all the time. We take history, as I said, examination. If on examination the prostate feels more abnormal, then we start, or the PSA is high, then we forget a little bit about your waterworks problems and we start investigating you for prostate cancer. And that's why examining the prostate is very, very important together with the PSA. If the residual is quite high, then we start looking to see, as in the urinary residual, then we have a look at the kidneys to see if the kidneys are blocked or if you actually need a catheter because you haven't been emptying properly. Taking all of that into consideration, if you don't have any treatment already, most of the time we start with some tablets. We have algorithms regarding the size of the prostate. What do we do? And the symptoms, do we watchful wait and not do anything, just give some educational advice? Sometimes we give some tablets to treat the overactivity. Many times we give a tablet which relaxes the neck of the bladder to allow you to pee better. And when all of that fail, then we talk about surgical treatment. Medical therapy, every treatment has its own side effects. If the side effects are worse than the benefit, then we wouldn't give the tablet. So alpha blockers, usually the first line, most men over 60 or 70 who have issues with their waterworks have a tablet called tamsulosin or alfuzosin or doxazosin. These are tablets which relax the neck of the bladder. But by doing that, they can drop your blood pressure a little bit. We've got tablets which can reduce the size of the prostate, but unfortunately, these many times come with sexual dysfunction side effects, and therefore many patients just step away from them. Maybe 20 years ago, these were really good, but nowadays sexual function preservation is at the top of our priorities, and that's why we don't give a lot of finasteride or dutasteride like we used to give before. PDE5 inhibitors, which are tablets which initially were given to improve on erections, and we found that they are better for, they are good as well for waterworks. Anticholinergics, beta-3 agonists, all of these are tablets which we can give. I wouldn't get into too many details, but those are usually decided when you are in clinic and when you see us. What I need to talk to you about is the surgical treatment of an enlarged prostate. So in the past, any patient who the tablets haven't worked would have a big operation to take the prostate out. Now things have changed. So when you come to see us and you tried some tablets and they don't work or they stopped working, or you're not happy with the side effects, then we start talking about treatments. There are many treatments, from surgical removal of the prostate to shaving down of the prostate to vaporizing it to injecting it with steam therapy. So simple prostatectomy, it's one of the oldest operations that we do for the prostate. We still do very rarely for the very, very big prostates, where we make a cut either using a robot or with keyhole surgery, or even with open surgery, where we make a cut, we go in, we remove the prostate, as you can see here. If there are stones in the bladder, we take them out as well. But unfortunately, this is a bit more morbid as a procedure. There's a bigger length of stay, bigger risk of complications and bleeding. Shaving down of the prostate, which is called a transurethral resection of the prostate, has been considered as a gold standard for a long time, where a hot loop is used to shave down the prostate, as you can see. That we pop a camera down, and with that hot loop, start shaving down the prostate. But that isn't the gold standard anymore, but it's a reference procedure because it has been there for a very long time. It's a good operation, but as well, it has side effects, which mainly are based on bleeding or and staying a bit longer in the hospital. But in experienced hands, this still is a good operation, and you can see a wide open cavity which can be obtained. Now, there are other treatments, surgical treatments for the prostate. So as you can remember from 2-3 slides ago, when I showed you how to remove the prostate fully with a hand or with your fingers or with the robot, we can do that using laser. So as you can see here, with the laser fiber, we can just go around. So if this is the prostate, we can go around it with the laser and remove that prostate fully, throw it into the bladder, and take the fragment out. That is a very good procedure. It's very durable. It has been done for over 15 to 20 years. The problem is that it takes long to do the operation, and the learning curve to find a surgeon who actually knows how to do it properly sometimes is problematic, as with the learning curve comes a very small risk of incontinence, and that can be mitigated. But for the very big prostates, this remains an excellent operation, which is called the holmium laser enucleation of the prostate, or HOLEP. Green light laser. So I'm giving you too much information, but that's how the last few years have been going through in the development of treatments for enlarged prostates. Green light laser, I do a lot of this, and it's an operation which is very good for the bigger prostates, for patients with catheters especially. It has been done over the 20 years. It has developed over 20 years or over with the stronger lasers and better technique. So basically, we pop a camera in, and using a laser fiber, we vaporize, we basically melt the prostate, where we create a cavity in the middle to allow you to pee better and to get you rid of your catheter. It's a very good operation. You usually would go home on the same day or the following day, and will give you immediate relief of the symptoms. But it's a bit more invasive than the newest of techniques, which we will describe very soon. Green light laser had been very good, and when the bigger studies were done, the study called the Goliath study was done, showing that over 93% of patients were very happy and would recommend and undergo this procedure again. Now, the newest kid on the block, the resume treatment. It's quite fascinating. It's an operation which initially all of us thought that it's too good to be true, but actually, 5-year data came to show us that actually this is a very good operation. So basically, it's a system where we use sterile water to inject it into the prostate. So like you've seen in the previous images, we pop a camera, all operations except for the open surgery or the keyhole, all operations involve a camera down the water pipe. We pop a camera in, we find where the prostate is, and we inject heat into it. Every injection takes around 9 seconds. So you can imagine that how quickly the operation is done and how rapidly where the patient is out of theater. It's a potential alternative to BPH medications. It relieves the symptoms quickly. The symptom improvement is noticeable very quickly. It can be done outpatient or in theater. I and most of surgeons in the UK, we still prefer to do it within a theater setup. It does preserve fully the sexual function and the ejaculatory function, and it allows the patients to return to their regular activities. So basically, this is the machine. I call the kettle, where it heats that water. That water is delivered through this handpiece, where once we get into the prostate, so this is the bladder, this is the prostate, we simply inject heat into the prostate at a single point or multiple points, depending on the size of the prostate. Once the injection is done, we come out, and that's the whole operation. On average, it takes me around 5 to 7 minutes to deliver the whole procedure, and together with the general anesthetic, it takes around 10-12 minutes altogether from the point of entry until the patient is back in recovery. You go home on the same day with a catheter for around a week or so, just to allow things to settle. And after that, catheter is removed and you're back to normal. And the prostate slowly and gradually starts to shrivel, like drying a fruit. And in a few months' time, the difference is noticeable. So as I mentioned, it uses convective energy to deobstruct the prostate. The 5-year data is out, showing that only 4.4% of these patients needed retreatment, which is an excellent outcome from a durability point of view, which actually showed us that what we doubted 5 years ago actually is a very, very good operation, very safe, rare side effects, and preserves the sexual function. You can see here in the 5-year data, it showed that the scores, the speed of the urine, the emptying of the bladder, all of those have improved, and the patients were safely treated with it with a very low re-intervention rate. But what really matters is when we see you in clinic to decide what treatment is best for you. Thank you.
Welcome you both back, and I can direct those to you if that's okay. So we've had a few around the same topic of BPH, interestingly, from a few different individuals. And it is in regards to the testing and regularity of testing with GPs, and in regards to patients who are possibly asymptomatic and false positives leading to maybe a distressing diagnosis, which later is not a diagnosis. So maybe you can both add comment on that if you wish. Thank you.
You want to start for us?
Absolutely. I mean, when we talk about the symptoms, basically we always want to be able to assess the patient depending on their history and what are the risk factors when it comes to any of the symptoms. Most of the symptoms of any disease are general, but once you see the patient in clinic, then is the moment where you decide, okay, more is needed to be done. And it's quite intricate, and that's why probably Dr. Al-Hassu will have a more in-depth reply to when it comes to prostate cancer rather than when it is for enlarged prostates.
So I suppose thank you. So I suppose the testing mainly is in relation to prostate cancer would be sort of the PSA, and this is actually a very good question, because it is the debate. Should we be screening everybody? Should everybody sort of aged, I don't know, 60 or 50 get a PSA done? This will lead to a huge number of patients being diagnosed perhaps unnecessarily, and causes undoubtedly a lot of anxiety. And in fact, in the US practice, they are more towards the screening, PSA screening, as compared to Europe or the UK practice in particular, because of this issue of overdiagnosing prostate cancer unnecessarily. So, and I agree with the point that when we actually see the patient, so if there is a PSA rise in somebody, for example, who have other medical conditions like heart, diabetes, ischemic heart disease, diabetes, or kidney problems, where actually a slightly raised PSA may cause a lot of anxiety, but it's actually of no clinical or practical relevance. Okay, whereas somebody else obviously may be more relevant in that. So I think it is, at the moment, it is really the jury is out as far as our UK practice is concerned. We feel that I think we will have to maybe individualize and be selective at the moment in testing PSA in particular.
Thank you, that's perfect. So our next question is in regards to prostate health, and if there's any advice on a dietary supplement or lifestyle to maybe improve or maintain.
I mean, I can comment on the oncology side, perhaps, if there is any diet or dietary effects. I would say, really, the evidence is very conflicting. There are some data to say, oh, yes, if you avoid red meat and high-fat diets, you may have less risk of cancer, or if you have selenium, green tea, and so on, that can maybe sort of protect against cancer. The reality is, the evidence, I think, as far as I can sort of remember, very conflicting. There has been, about maybe a few years ago, a talk about something called POMI tea, which is pomegranate and tea extract mixed together and made in a tablet, and I think is available, and a lot of people started buying it on the basis that this may actually protect, because it has a lot of antioxidant in it, but the evidence has not actually proven that. So at the moment, in my practice, I say to patients, actually, I think eat a healthy diet. That's all what I think we can say at the moment. Nothing specific that will lead to cancer, or nothing specific that will prevent from cancer. As far as BPH is concerned, I'll leave that to you, Firas.
Yeah, thank you, Abdullah. around the same lines. So it always has been on my mind, and I always did have a deep interest in metabolic syndrome, which is a disease where there's diabetes and increased weight and waist circumference, and we saw that in these patients they do have slightly bigger prostates. Not from a cancer point of view, although some work has been done by our Oxford colleagues in the Nuffield in Oxford, where they were looking at advanced prostate cancer and these metabolic syndrome patients, but nothing is absolutely confirmed. So yes, the data is conflicting. What I always tell the patients, try to avoid whatever is causing the organs to increase in size, and the organs do increase in size with fatty food because there will be fatty infiltration. And because the prostate, the edge of the prostate where there would be cancer is of less relevance to the meat of the prostate, which will cause your urine to block. So that meat of the prostate is what we want to reduce in size. And I did see indeed that in slightly bigger patients, they do have slightly bigger prostates. And I'm not sure if it is related. So I always tell patients as well, like Dr. Al-Hasso, to have a healthy diet, antioxidants, omega-3, all of these habits that you have anyway to reduce the fat in your food. Keep a healthy diet is what I would advise you.
Maybe I could just add just another point in relation to other sort of medication that one can take. There is actually, because of the lack of clear direction of what we should be telling patients, there is an ongoing research work at the moment as we speak. There is a study in prostate cancer called Aspirin study. And aspirin is obviously is a very commonly used drug in patients with heart problems. And it has been shown in cardiac research that actually it can potentially reduce risk of cancer in general, not just so prostate, breast cancer in ladies, upper esophageal cancer, stomach and colon cancer. So the evidence wasn't really very strong, but at the same time, it's not something we can ignore. So therefore, there is an ongoing study, and we are actually taking part in this trial here at the Beatson, where over 10,000 patients is getting recruited to try and see, does this actually really have an effect? So it's a placebo control. So some patients will have aspirin, others will have a placebo. And there are about, I think, around 3,000-4,000 prostate cancer patients, another 3,000-4,000 breast cancer patients going into this trial. And so on. So it is work in progress, but at least there is an ongoing active research in this field.
Thank you very much. The next question has actually come in for both sides. So the spacer procedure and the resume newer technique for BPH management. In regard to the availability on the private and public side across Scotland, would both of you be able to give a little overview of how that looks currently?
Abdullah, you can. No, you
okay.
can.
That's fine. Thank you. Right. Okay. So for spacer, obviously it's a relatively new technology, and what we are using, in fact, Darragh know that we've actually started this at the beginning of this year, and we have been using the hydrogel view device, which is the most modern and the most advanced technology. And we found that this is actually really great. So in the private sector, it's available, whether patients are insured or self-pay. And usually this is, we are currently doing this through the Glasgow Nuffield Hospital. And it's just basically a direct referral from the supervising oncologist to myself at the Nuffield, and we can do that. Obviously, assess the patient first and then proceed. Within the NHS, while this is currently is being sort of approved by NICE, But NICE obviously is a body that applies to England and Wales, but not Scotland. So within Scotland, there is a health technology assessment to look into this. But for us in the Beatson, for example, we felt that there is enough evidence, enough to justify starting a pilot a project within the Beatson for small group of patients who are more at risk of having rectal toxicity from radiation treatment. And we have selected criteria for which patients are applicable to this group or this pilot. So we are doing it on a very limited scale. At the moment, it's mainly, I have to say, I think the technology is great. We have the expertise and the equipment to do it within the NHS as well. But the cost is a factor for the NHS, because we have to think about all the population. We cannot think about it sort of individually. It need to be either all or none. So at the moment, we are gradually going to expand. At the moment is really limited to patients who have some pre-existing medical condition that affect their rectum, and they are more at risk of this. And if the patient fulfill that criteria, we will be able to do it.
Thank you. And regarding Resume, at the very moment, NHS 5 within the NHS in Scotland is the only hospital in the whole of Scotland offering it. I had, and I still have, visits from colleagues from all over Scotland to my theatre very regularly, colleagues, urologists, watching the procedure and wanting to introduce it to their hospitals. I recently, last week, had a visit from colleagues from the West Coast as well, to look into the procedure to see whether they can implement it. And I offered I can go and help as well. So I'm hoping that soon more and more centres within the NHS within Scotland will be able to offer it, as it's quite a quick procedure with an excellent outcome. But as all things are, when there's a cost implied, within COVID as well, all the hospitals need to be weighing risks and benefits when they're introducing new procedures. In the private sector, we do offer it in Spire in Edinburgh, and I do get referrals either directly, either self-referrals from yourselves or by the GP. And as with all procedures, it can be done for insured patients and for self-funding as well. So these are the two ways that you can have the procedure done, either to have it done privately or to have it done on the NHS if your local trust is offering it. If not, and you still want to explore being referred to me in Fife, then you can have that done, but it's a process where the one trust will have to write to the other, and but everything is possible. Yeah.
Just to say, I think this is all the same sort of scenario happen with any new technology that get introduced. It is more challenging, obviously, in the NHS, given that it is a much larger scale, and you have to think about it in a much bigger sort of picture. So that applies to even medical treatment, drug treatment, and any other sort of technologies. But like yourself, for us, the pilot for the spacer in the NHS is actually obviously limited to Greater Glasgow and Clyde only. It's just not possible to accept from elsewhere on an NHS basis at this stage.
And it's the same as Dr. was saying. It's the same. Every trust will be offering whatever they offer, and only on exceptional basis they do take from other trusts when it is a new procedure. Yeah.
That's great, thank you. I guess the fact that the Men's Sheds network is so wide across Scotland, we will have people listening into this from all parts of Scotland, and with each area doing different procedures. I think the awareness side of it is important, that patients know what's out there and that they can assess their options and decide what's best. So just one final question that we have, and it is from somebody just asking about the function of the prostate, and if it is removed, say surgically, what effect could that have on day-to-day life? Yeah,
so it's a very common question, and And the answer usually is very frustrating, because the prostate is an incredible organ for fertility. So it's an organ which is there. It produces the PSA and the other substances which make the semen more fluid and more fertile. So that is mainly the only reason to have a prostate. Later on in life, it keeps on enlarging. Most of the time, it won't cause problems, but it can enlarge to a point that it squeezes the urethra and it causes obstruction. So in general, the function of it is in the fertile years. So if it gets removed itself, there wouldn't be an impact per se by removing the prostate, except for the ejaculation, because the semen will not have that spring muscle within the prostate to push it forward. But everything else within the limits of the surgery or the radiotherapy, which would be explained. But the organ itself, when we remove just the prostate, it won't harm the patient, no.
That's perfect. Thank you very much. And I think that's all from our questions.